Okay, well, it's a little afternoon, and I'm going to go on and proceed with a roll call.
Do you want me to do the roll calls for you, Paul?
Yes, go ahead and do the roll call.
Okay, John Eagleman? It's not here yet. Sabrina Pennington?
Here.
Robert Coddington?
Here.
John Lebo? Jeff Butler?
Here.
Pete Zaleski here, Paul Ryder?
Here,
So that's 5 out of 7, so that's a
so
quorum.
we have a quorum, and I call the meeting to order. First item is approval of the minutes. You should have all received the minutes of the last meeting. Any questions? Is there a motion to approve?
So moved. Second.
Okay, Jeff Butler made a motion to approve. Is there a second?
Second.
And Bob Connaughton seconded. All in favor? And that's, I'll only do a roll call if anybody objects, so.
Okay, John Eagleman? I'm sorry, Sabrina Pennington?
Yes.
Bob Coddington?
Yes.
Jeff Butler?
Yes.
Pete Zaleski, yes. Paul Ryder?
Yes.
Be careful with this. This is in case anyone falls in.
And the next item of business is discuss school opening, and we have several guests.
Is now in the conference.
And Christina, do you want to handle
Yep,
this aspect of it?
sure. So as a lot of you know, there is a school reopening plan that IDOE and ISDH has worked together to put out guidance to the schools on formulating a reopening plan. I've met with the schools twice. Monday was the last time that we met with them after I'd had a chance to have a conference call or a webinar with the state to kind of give the health department direction on what we're to direct the schools for good policies. One of the best things that came out of it was that we do not have to sign off on their plans. So there's no responsibility for the health department to sign on their plans. And I think one of the biggest concerns that's coming out of the schools is the recommendation that they require masks to be worn when they cannot get 6-foot separation and maintain that 6-foot separation. So they talk about a lot of their classrooms, they may not be able to achieve that 6-foot separation. Definitely on the buses, they're not going to be able to do that. So, what are they going to be able to do? And like I've said, the health department, we have no requirement to sign off on the policies to the schools that they present to us. We can give good advice and guidance on those, but they're under no obligation to follow what our recommendations and guidances are.
John
this is-
Eagleman has
Go
left
ahead.
the conference.
If someone wants to speak, please announce your name and institution.
Yeah. Is there someone from the school that you guys have decided to be the one to talk?
Is now in the conference.
George was kind of the one that I had been done most of the talking with Western Wayne Schools. Is he on?
Yeah.
Yep, this is George.
Do you,
I think, I don't know, I want to speak for everybody, but a challenge for us was that we received a plan from the Department of Ed that in just about every paragraph kind of sent us back to the Wayne County Department of Health. And so, at least for me, it's important that whatever plan we come up with is at least able that, whether you physically sign it or not, that you at least endorse that plan. My biggest challenge, is that I'm not trained in any kind of health related anything.
hey, you guys. Hey, can you hear
I'm
us?
hoping for some help in figuring out all of the safety precautions that we follow.
This is Dr. Ryder, and I noticed that the CDC released their toolkit for analyzing on reopening, mid-May. I assume you've all looked at that? Or have you even seen it?
We're really going off of the DOE's 38-page document regarding reopening schools and the recommendations that they include in there. And as George said, most of those then refer you back to the local county health department if there are questions or for further guidance.
Okay, you want to identify yourself?
I'm sorry, this is Todd Terrell, Richmond Schools.
Okay. This, Dr. Ryder, I think it would be helpful to the board if you would send us the document you're working from.
I believe I've already sent that to you guys.
Have you already sent that out?
Yeah, I sent out that recommendation to them. A lot of the things that they refer back to comes down to when we get positive cases, when do we recommend, what's that threshold to close down schools? What's that threshold to close down a district versus the entire county? And we'll look at a lot of things, and I don't have a magic number of when do we recommend closing schools versus districts versus the county. We'll have to get far more into this. Right now, we're just looking for good policies for the reopening of schools and how we can mitigate closing of classrooms and having to send lots of kids home, how we can do good case investigation and contact tracing. When we have policies where there's masking, when we have policies of assigned seats on buses, classrooms, lunchrooms, where we can cohort better and understand if we have John comes down with COVID-19, who then are considered his close contacts. The more we are able to identify them, we can individually put people into isolation versus wide sweeping. Everyone that was on bus 12 is in isolation now for 2 weeks. We want to try to avoid those kind of mass isolations when we get cases. Dr. Box on the webinar that was done for the schools on Tuesday, the question came up about masking, and she said, you know, if you take nothing else away from this webinar and what she has to say, it's the importance of masking. The way that we can reduce the spread of COVID-19, we know the number one thing we can do is mask and the physical separation between people. We know in schools we're not going to be able to maintain and achieve that 6-foot separation. While Dr. Box would like to see sweepingly the requirement of wearing masks, in Wayne County, I think it would be a good policy that it's strongly encouraged that everyone wears masks, but when we cannot maintain and achieve 6-foot separation, it's a requirement to put a mask on. And that's for staff and students. And then it would be up to the schools. I don't want to see any child, you know, put out of school because they are refusing to wear a mask. That would then be up to the schools to enforce their policies. But I think good public health policies have masking in place, and it is a requirement of masking.
This is Todd Terrell from Richmond. Christine, I think as we talked as superintendents with you, that one of the things we talked about was rather than saying they're required, was saying that they are recommended, and we talked through the possibilities of saying that we're going to enforce that policy and the challenges that come with that.
Yeah.
Have you changed your thought as far as the language goes with that, or are we still continuing with the recommendation of it?
No, I've always said that it should be a requirement. When we can't achieve and maintain the 6-foot separation, the policy should be a good policy for public health protection is the requirement of mask wearing. Where in the other situations, it's a strong recommendation for the schools to have all staff and students to have masking on. But when you cannot maintain and achieve the 6-foot separation, it is a requirement.
This is George from Western Wayne. And I think that the challenge that the 5 superintendents have is is what does require mean? If required doesn't mean we're going to send you home if you don't have one on, then what does require mean? And if require doesn't mean require, then what's the difference between that being written?
Yeah. And that's
versus
for you
recommended?
guys to decide. That we're not going to get into the running of the schools and how you make a requirement stick. That's for you guys to enforce those requirements. I don't think that we're going to get into the guidance of that. I think you want to say something.
Well, and you have dress code policies that you guys follow in the same way that you would monitor and act on those would be the same way that you would act and monitor a face mask policy. And I'm not running a school, but I'm just trying to think of what you already have in place, and if it's added to a policy you already have and are enforcing, it seems like that would make sense to add that to that.
Yeah.
Guys, here's the challenge with all of this, and that is, as we look at policies to enforce, so what happens when we show up at 6:30 in the morning to pick up a kid on the bus stop and he doesn't have a mask on? Do we leave him out there in the dark because he doesn't have a mask? What happens if we come in and kids refuse to put them on? Do we send them home? And what does that look like? So while it sounds like, yeah, we can enforce it and we can just require that, the feasibility of that realistically is just not something that's there. And we have to try and balance that with, if they're not in school, what other risk are they exposed to at home?
Yeah.
And what are they facing there that, in my opinion, are a heck of a lot worse than what they're going to face with this?
I absolutely agree with you, Todd. I think that the most important place for the kids to be is in the classroom, is in the school. And I think when we have good masking policies, especially when you can't achieve and maintain that 6-foot separation, you're going to be able to see schools stay in session longer. And when we don't have good masking policies, and we know that masking does work in reducing transmission, that we're going to be able to keep kids in the classroom longer than if we do not have good masking policies that require all students and staff to wear a mask when they cannot stay 6 feet apart.
Now, this, Dr. Aaron, my understanding is that the state is willing to provide masks, but they had a survey that you needed to complete, I think, by today, and indicating whether you were requesting them or not. Is that correct?
This is Todd Terrell. Yes, that is correct. And we have completed that survey. Part of the problem that we're looking at is with disposable masks, we're talking between 6,500 and 7,000 masks that we're going to need per day for all of our students, staff, and teachers. And that is if they can keep them. So we're talking about first graders not doing something where they need a new mask or throwing it away, and continuing. So you can look at the volume of that as it comes in. And I know there was some talk about cloth masks and being able to utilize those. And again, they need to be washed every day. Guys, realistically, we all have kids who they probably haven't had their clothes cleaned since we shut down school, yet alone washing their mask every day as they come in. So then we talked about the process of, well, what if we washed them at school? Well, can you imagine putting 600 masks through the washing machine and then just pass them out as kids come back in the door, not knowing who's getting whose mask from the day before? Logistically, it's just not feasible. And if this is something that is going to be a requirement of this, then I'm not sure that any of us should ever be in school. But yet when we open our state and we open up every other possible venue where people can be there and do whatever, go to games on Friday nights at the stadium and have 3,000 people there, go to Kings Island, go to the mall, go to Applebee's, McDonald's, whatever it may be at 100% capacity. And then as soon as they walk through the door at 7:30 on Monday morning, we're expecting something totally different. The challenge there is going to be people aren't going to put their kids in school. The challenge there is that people are going to say, why are you doing this? The surveys that have gone out to parents, and the other 4 superintendents can speak to what they found, their parents simply aren't interested in requiring their kids to wear masks all day long at school.
I will tell you, we get calls all day long saying that from parents and staff members wanting the health department to have this requirement. And I've explained again There is no requirement that the health department sign off on any of your plans. So you can open your school with the policy that does not have this requirement. That is not gonna be any rub against the health department or anything. Open your school on the policy that you feel is the best for your schools. But for the health department to have a endorsement of it, it will have to have the requirement of requiring masks when you cannot achieve and maintain the 6-foot separation. Are there any other things that need to be talked
See, what
about?
does that mean for the health department to have enforcement?
I didn't say enforcement, I said endorsement.
Okay, I'm sorry.
Yeah, the health department will not enforce any policy or any recommendation or anything for schools. Even if you have in your policy that you're going to require a mask to be worn in certain situations when you cannot maintain a 6-foot separation, the health department is not going to enforce any of these policies.
I totally agree with that.
Yeah, this is Dr. Ryder again. Well, I think there is a dilemma. Best practices is that if you have group meetings, particularly indoors, and you can't maintain physical separation of the 6 feet or so, that you wear a mask. That's best practices from a medical point of view and from public health point of view. I think we're all struggling with how best to accomplish that. And it appears that we don't have the tools to enforce it if people refuse to do it.
Well, are the teachers willing to wear a mask? The school nurse, the custodian, the adults that are involved, Todd?
You know, I think that just like with our kids, we're going to have some who want to, and we'll have others who will not want to.
Yeah.
And so I really think, again, it has to come down to that recommendation to wear a mask. And if they refuse to, none of us, and again, jump in other soups if you want, none of us believe that we should try to enforce our teachers to have to wear masks when they're in that classroom. Now, if they get within, that bubble of space that we're talking about here for more than 15 minutes, from what I understand from our conversations with Christine, that's where we really have to become more concerned with that. So at this point in time, I don't think I can say that our teachers are willing to or unwilling to, because we simply haven't had that conversation yet with them. But all of us feel like our recommendation would be to them to wear masks. But as far as going to say that we're going to require that for them to be at work that day, we're not in the position where we feel comfortable in doing that.
Well, it would certainly be prudent, because the people that are most at risk in this whole environment are the adults, not the children. And I also think it would be very difficult to ask the children to wear masks if the teachers and the other adults in the school system don't. So that would be very problematic.
Paul, John joined us on the phone, and I think he had a comment to add. John?
Okay.
Dr. Eagleman?
No, I did not have a question, sorry.
Okay, I'm sorry.
Is Lebo on the phone also?
Yes, I am.
Okay, John, did you have something?
Well, I said my concern was in the beginning, when a student comes to school without a mask, that we would provide one. And I think I got that answer, okay?
Okay.
And then I also was thinking, as a former school administrator, I think that it's prudent that everybody would wear a mask. But if they don't, that again is up to the administrative staff, what action they would take.
Yeah. Thank you. Are there any other questions from the superintendent?
Hi, this is Roxanne Steele with True Blood Preschool. I'm part of Richmond Friends School. So with the preschool population and in our pre-KK classroom, we use tables instead of desks. And so we are actually talking about keeping our classes together and not mixing classes, doing cohorts this year. And so we avoid classes mixing in the cafeteria and on playground time, but obviously while they're eating lunch and snack, or even if they're at the tables doing work, we're not able to keep 6 foot distance at all. But I have a hard time seeing preschoolers using masks well. But it says the mask recommendation continue all the way down through the 3 to 4 and early young 5s, or is this really more of an older child, or do you have other recommendations for us?
I think that the recommendations that came out of DOE were for kindergarten through 12. So
Okay.
I don't have a recommendation from ISDH for preschools, but I could look for that.
This Dr. Ryder, I believe the American Academy of Pediatrics doesn't recommend masks under age 2.
Okay.
Well, if I can build, I'm Joe McHugh. I'm with Roxanne at Friends School, Richmond Friends School. Help me, some of you help me understand how you do lunch, how lunch can happen. I'm struggling just to imagine.
Yeah, have you read the recommendations for the DOE?
I'm still not clear.
I would reach out more to the DOE on their guidance if you're confused on transportation or the classrooms. But again, cohorting, assigned seats, everyone facing one direction when you're eating, and the physical separation, from what I've read, are what they're recommending on these. And I know these are all challenges. I absolutely understand that this is not the conventional way that any of us want to see schools to continue. But until we have either an effective treatment or a vaccine, we have to look at ways to reduce the spread of the COVID-19 in our community.
So you're saying also that if we're in a lunchroom, we still have to have 6 foot separation?
Yes.
Okay. And let me ask another question. If we do something like extended care, like in the morning or in the afternoon, we have to have separation. We have to have 6 foot separation to be able to do that, right?
I believe that the DOE is asking for 6 foot separation anytime it's feasible.
All right.
And that
feasibility?
That feasibility is decided by you.
Right.
The school is who. I don't come into your school, or Dr. Ryder or Dr. Jetmore or anyone on the board come into your school and say, it is feasible for you to do this. You're the ones that decide what's feasible.
Okay. Okay, kind of.
If there's no more general questions, I'm sure that we can have another meeting with school superintendents where we iron some other things out, but the board has other
And I guess,
things that we have
I
to
just have
get
a
on.
question on next
Yeah.
steps, because are we gonna ask at some point to endorse these plans? Or is that something that Dr. Jetmore in his role is doing, or is it a board endorsement? I'm just,
So the schools have asked for the health department's endorsement on that, whatever that means. Either it's the president of the board, Dr. Jetmore, myself, to endorse the school's plans. And I've explained that kind of that minimum threshold is, along with good cohorting policies, is that the requirement of masking when you cannot achieve and maintain that 6 foot separation. That those would be the only plans that the health department would endorse, because there is no requirement for the health department to do this. We do not have to endorse anyone's plans. And I think that the board, the health department, should only endorse good public health policies that require masking when you cannot have the 6 foot separation.
okay. I was just thinking, if the board's gonna be voting on this, at least I can speak for myself. I think that would be the requirement I would want in there for me to vote in favor of endorsing a plan.
Do you wanna vote on that, Dr. Ryder, or do you wanna get all the school's plans and then have
I think the question is, do we want to endorse any plan?
okay.
Period. We're not required to endorse a plan. I think what we're being asked to do is be a consultant to the schools to answer their questions and to provide guidance and recommendations, but not to endorse. So I don't know that I want to even put us in a position of endorsing a plan, but I think it would be wise for us. And one thing to consider, do we want a subcommittee to meet with you and Dave to be available to the schools for that consultative function?
I would say I've talked to a couple of other health departments and asked them if they're going to endorse any plans, and the 3 health departments that I've talked to have said they're not going to endorse any. They're just the same thing. They're offering good public health policies, and the schools, since we do not have to endorse them or sign off on them, they're not going to sign off on any.
As attorney for the health department, I would strongly endorse Dr. Ryder's his thoughts. I do believe that the role of the local health department is to be an advisory body and be available to give advice and answer questions. If you look at the CDC's documents, they make it very clear that there's a continuum of risk. On the one hand, there may be the minimal risk associated with full social distancing and masking. On the other hand, there may be no masking and failure to maintain social distancing. The schools are the ones that are going to have to do that analysis of the risk benefit and on any particular issue. I think the role of the health department is to be available to give its best advice based upon medical concerns. But I don't think the role of the health department is to basically approve or disapprove of a school's plan.
Okay. So George, does that answer your question?
It kind of does. The challenge is that I don't know that any of us in the education field are qualified to do what we're being asked to do. But I guess these are just unprecedented times, and we'll move forward.
Yep.
You know, this is Dr. Ryder again. I wonder, I mean, we have some people, I mean, I'm a pediatrician. John Lebo is a former school administrator. Of course, there's Dr. Jetmore. Pete's a parent. I wonder, I think maybe it might be interesting to have a subcommittee that's willing to meet or to meet and answer questions that the schools have, other than just putting the entire burden on you and Dave. That's something we could do.
This is Roxanne Steele again. So in those guidelines, they refer back to the schools contacting the health department if we have a student or a student's family that tests positive, and then the health department will give us guidance on where to, whether we're to close a classroom, a school. In our case, because we are a small school, it sounds like you guys will make those decisions individually, case by case, at least initially, is your thought?
Yes.
Roxanne, I think one of the things that's important, Christine talked about managing cohorts of students. I think assigned seating on the bus, or assigned seating at a table, or assigned seating at a desk in a classroom will really be helpful if there's a positive case, because it's going to allow us to sort out who the close contacts of that student was, and to be able to trace the course of the disease if it occurred. So that would really be helpful, having assigned seating of the students and kind of trying to pin down where they are during various parts of the day.
And we can set up another time to meet next week once you guys kind of have your policies or your plans more concrete, and we can go over them again. And maybe Dr. Ryder or John Lebo would join that meeting with me. Would that be agreeable to everybody?
Are you asking the schools or are you asking the board?
Yeah, no, I'm sorry, I was asking more of the schools. Where do you want to go next with the health department? Do you want to get your plans finished and then meet individually? Or I think all 5 of the school superintendents were looking to do very similar. So one school isn't an outlier. Do we want to all get back together and go over the plans again? Do you only want to call me when you want to talk, or do we, I mean, we don't have to need to know today, but I can bring Dr. Ryder or John Lebo to the meeting as well that could maybe answer some of your questions that come up in the planning of your reopening plans.
We realize, this is Dr. Jugmore speaking, that we're asking you to educate children in the middle of a pandemic, which is basically impossible. So we want to do everything we can to help you, and if there are individual questions that come up before the school year starts or during the school year, we'll do everything we can to help you make decisions on what to do.
Yeah. And I've also, with each of the districts, and I'll reach out to the public schools with bringing immunization clinics to you. I would like to bring those to each one of the districts. At the minimal, do a flu clinic in each district. I think the more that we can reduce flu this fall and the impact of the seasonal influenza, the better off we're going to be as far as having to isolate and close down classrooms or buildings. But also to do immunization clinics. We do know that immunizations around the state have been impacted too by the COVID-19. So working with the schools to make sure that our immunization rates are not hurt and we don't have an outbreak of whooping cough or measles in the middle of this pandemic. So we'd like to work with the schools on that, and I can work individually with the districts on those flu clinics, and if you want to do an immunization clinic, doing that too.
And this is Dr. Ryder.
Christine, we appreciate that offer, and we'd be more than willing to work with you on a continuous basis. We do plan on all having a very similar plan as we move forward.
Yeah.
One of the things that we're going to do is to talk with other regional school districts around us and around the state and see what their plans are looking like so that we can match those up and be similar in our approach with that. For the rest of the board, just one thing for your consideration and understanding. So in that 38-page document that you've received, there's also the IHSA guidelines for athletics and what that looks like. And part of the problem with this and our frustration is we're talking about masking kids from the moment they get on a bus to the moment they get off a bus. But yet we're letting them go out to practice at 3:30 and smash up against each other playing soccer, and then get on a bus and ride 3 hours to Logansport to play them, or them come here, vice versa. And so we have this mixed message of, in the building, they have to do this. Athletics is totally different and it's wide open. And then free time at home and on the weekends is whatever they want it to be.
Yeah.
So for us, we really have to balance. And I get that everybody says best practice is wearing masks, but we really have to balance what it is that our expectations are of our students and our employees, again, with everything that they're doing after 3:30, even from our athletic events. So that's the challenge we're all facing. We're not asking you to give us anything more with that. We just want to make sure that you guys have an understanding of what we're trying to balance and what we're looking at with it. And we appreciate the input that we've received thus far. The health department has been a huge help to us, and we appreciate that. And I know we'll get the same going forward.
This is Joe McHugh again from Richmond Friends. I'd like to underscore or support what Dr. Ryder mentioned. I would personally find it very helpful if we could have a call or something with the medical professionals, just for us as educators to get decent advice about best practice, because I find it, I just find it confusing. We're listening to a lot of different things, but I think I need some really hardcore, good medical advice. That's what I don't know if anybody else would find that helpful, but I would find a call where we just did that, I would find that very helpful.
Yeah. This Dr. Ryder, and Christine, I'm certainly volunteer, and whether you and I and Dave wanted to set up a time with each school that wanted to talk to us on some of the medical aspects, it might be best on. We could do it in small groups, we could do it individually, whatever works, but I'm certainly willing to do that.
Yeah, I will tell you, my time is incredibly limited, so doing one-on-one with the schools, it's almost impossible for me. The superintendent meetings that we have been having, I think have been beneficial, so all the schools are hearing the exact same thing. It's one time, it's, you know, not that every school isn't just as important, but I'm getting pulled in a million different directions. So the one meeting would be my preference.
If that's what works best for the department, but I'm certainly willing to be present at that meeting.
Okay, I appreciate that.
You know, just an addendum on that. I mean, I appreciate the public school systems have a lot more support, and I think have opportunities to cooperate and put their heads together. What I'm thinking of are the smaller private schools that do not have a big superstructure to relate to and are, I think, maybe struggling a little more for some support and knowledge. I would just speak to that. I mean, even if we could do I mean, I've talked to people from Seton, I've talked to a number of folks, and even if we were able to do a call, not individual with everybody, but maybe to do a call where we could talk about if you're willing and able to do something with some of the independent schools or private schools, because as I said, we're sort of out there trying to struggle to get information.
Okay, this is Dr. Ryder. Any further comments or questions from our guest?
Do we have another meeting? Do you have another meeting scheduled with the superintendents already, or is that?
I don't, but usually I work with either Todd or George, and they get it out to everybody. And we reach out to the private schools to invite them to it as well. But between them, we can get one. And if we want to have one for public schools and one for private schools, I'm not opposed to that. I just can't meet with each individual schools.
Yeah, I get that. Yeah, totally.
So if one of the superintendents of public schools would reach out to me and set up a meeting, I'd be more than happy to set with Dr. Ryder's schedule and make sure that he's there. And then the same with the private schools, if you'll all work together and contact each other, give me a couple of dates that work for you, we'll get it on our calendars with Dr. Ryder. And we can either do a Zoom meeting or in person. With the superintendents, I have had in-person meetings with the superintendents, and we'll continue to do that.
Christine, you're at the Wayne County Board of Health, is that?
I'm at the Wayne County Health Department.
Okay, all right.
Yeah. My email is...
Yeah, I'd be happy to do that, to reach out to you.
Okay. Have we emailed back and forth? You and I? I've emailed a few people with friends' schools.
Yeah, I mean, is your email on the website? If so, I'll just connect with you. So we have.
Okay. All right. Thank you, guys. We do need to move on from the schools. I appreciate your time, and I do appreciate everything that you guys do. I've told them several times, the only job that is worse than being the director of a public health department is being a superintendent of schools right now. So I do feel for you guys.
Yeah. All right. Thank you, guys. We appreciate it. Thank you.
This is Dr. Ryder. As this is a public meeting, you're welcome to stay and listen to the rest of the meeting if you want, but I think we'll consider this portion of the meeting as far as actively engaging with the superintendents in the schools is to be closed. So the next part of the meeting is the health officer report.
Did you guys approve the minutes?
Are you ready for me?
Ready for you, Dave.
All right, what's that sound?
Someone's not on
signing
mute.
up. Well, the coronavirus updates. our Optum clinic is testing on average 40 people a day. So people are utilizing that site. There's 4 other sites in the county where people can get testing. This is viral testing to see if you have the disease. And I think the hospital's almost on board, or maybe they already are, for doing antibody testing. So that can be.
First Care, I believe, was the other one.
Okay, so that can be done as well.
There's another place that's doing an American
Labs.
Yeah,
American.
I know one of you guys told me about it, so.
Yeah.
Okay, so as up to date, the county has had 277 cases of COVID. 106 of those were laboratory confirmed cases, and 171 were clinical diagnoses. We've had 6 deaths. I think of interest is, I think at the last meeting I reported about the state of Indiana doing 20,000 tests at random of Indiana citizens to see what the penetration was of COVID-19 into the population. Back in April, they found when were doing this in cohorts of 5,000 people apiece at 68 different testing sites. Back in April, they found that 1.7% of the people that just randomly were called in were positive for coronavirus. And this last series of tests done in June, that number had fallen to 0.6%, which is very encouraging. Back in April, when they tested for antibodies, they found that 1.1% of the people had antibodies. That's risen now to 1.5% had antibodies. This means people have had the virus and they've recovered. So that's also encouraging. If you look at on the state site, which keeps tab of where the coronavirus is in the state of Indiana, the testing keeps going up. The number of coronavirus positives that we're seeing is kind of plateaued off, and part of this may be because of increased testing. The number of deaths continues to decline rather steeply. So Indiana is doing very well. As far as the United States goes, 22% or 22 states are having an increase in coronavirus. That's particularly true in some fairly populous states like California, Texas, Florida. Oklahoma's having a problem, as is Arizona. So one of the dilemmas here is we've been able to drive these numbers down through mitigation, which is, you've heard it ad infinitum, washing your hands, social distancing, and wearing masks. But now we're coming out of this, these mitigation things are being lifted out of necessity to preserve our economy. And a lot of people feel like the epidemic is over and are acting in accordance with that. So I think that's the reason we're seeing these rises in many of these states, and why we're going to continue to see kind of little mini flare-ups of this pandemic. We're in the first phase of this pandemic. Only 5% of Americans have been infected with COVID-19. So basically the status of the United States is unchanged from when this began in January. 95% being vulnerable versus 100%. So this epidemic is far from over. We're in the first phase, and we'll have to see what happens. We're trying to thread that needle between keeping people safe and preserving the tatters of our economy. So that's where we are to date. We'll see what happens as we go forward.
Any questions? Thank you, Dr. Jetmore. Let's move on.
Okay. We are finalizing the plans for the build out of the clinic. As you guys can see, we've moved into our next phase to opening back up. We're not going to hold off on opening up the vaccination clinic until the build out's done, because to be honest, I'm not sure when it's going to be done. I personally think that it's going to be toward the end of fall before we're completely ready to open back up in our new home across the hall there. So this room that we're in right now will become the clinic. I've already moved the two nurses' offices in here. So our RN, Tammy Roberts, will be over here, and the LPN will be on this side. We are starting to look at the applications and call people in for interviews for that LPN position. We met with VFC Monday and got our order in for our vaccine stock through VFC. VaxCare was here, and they have purchased our private stock vaccines. And it was right around $14,000 worth of vaccine that they bought. There was about 300 doses of flu that were out of date that were given to us from the clinic, so we'll properly dispose of the out of date flu that we received. So that's where we're at on that. I do have a meeting on Friday with the architects. I believe that's the final meeting to approve the plans, and then that it will go to Indianapolis for their approval of the plans, but we can simultaneously put the plan out for bidding. We don't have to wait for the state to approve the plan before we move on to the next phase of putting it out to bid. Jeff, am I correct on that?
I don't know.
Okay. All right. I believe that that's what was talked about. So I think that we're still...
Ron may know that.
Yeah. I think that we're still on track to be able to at least start demoing by the end of July. But we're 90 days. First they said they'd be able to have this done in 30 days, then it was 60 days, now we're at 90 days. Scope of project changed a little bit. There was some things, the HIV area was added into the project for us to be able to, instead of piecemealing this together, just do it all at once and build out that HIV area. That brings me into the next area that's on the agenda, and that's the Ryan White HIV Care Coordination Grant. That was a really quick one that came up with a really quick deadline on the application. The 52-page application that we have, but basically it provides for care coordination. And we'll have, if we get the grant, it's a 3-year grant, $170,000 a year, and it'll pay for 2 employees and then the administrative cost of doing that. We'll contract again through Heartland Services, so we won't be bringing in more county employees. There'll be contract employees through Chris's company. But it'll provide 1 medical care coordinator for people with HIV or hepatitis C, and then there is a social care coordination position. And so we'll have the dual people. It'll be for Wayne and the surrounding counties, so it's not just Wayne County. They'll operate for, I believe it's Delaware J. I'd have to look at that grant. I did talk with the commissioners, and I'm on their agenda. I haven't gotten permission from the board, first of all, to apply for this, and then I have to go through the council and the commissioners also. But I did let them know that there was this tight deadline, if, for any reason, if the board doesn't want us to go forward, or with commissioners or council, we can just withdraw our application for this.
This was.
Ms. Dr. Ryder, do you have any specific concerns, Christine, that were problems that this grant could cause for the department?
I really don't, especially since there'll be definitely contract positions. I don't have a lot of concerns with it. A little bit of background, right out of college, I was a care coordinator through Open Door Community Services, and I provided care coordination for people with HIV and AIDS. That was, a little bit different time, but I was kind of the same project and program would be now housed in our health department. So I'm a big supporter of it. I think there's a lot of good that comes from this. I think there's a lot of better standard of living that we can offer people, and with hepatitis C, we can get it cleared up and them off of those roles. So
There was questions about this grant being a multi-county grant. Ron, was there some legality of the Wayne County Health Department engaging in a contract that involved other counties? Or I'm trying to remember that conversation from a few months back.
I wasn't a party to that conversation. Generally speaking, that there's the statute says the health department acts within its jurisdiction, but since this is not going to involve the direct employment of county officials, in effect, we are basically participating in a multi-county engagement, and that'll inure to the benefit of the county patrons. So I have no problem with that in this context. If we had our employees going out of county, that would be a little different situation.
right, yep.
Okay.
Is this a reimbursable grant, or how is it funded?
I don't believe it's reimbursable, but I can get that answer and send it out to the board.
Well, that'll be a question the commissioners and council have. I'm just going to give you a forewarning on that.
Yeah, I don't believe it is. I believe it's paid up front, more like the local health trust. But I will definitely have that answer, and I'll get it out to you guys. I'm sure it's in here somewhere.
So Chris and his staff are managing not just HIV, but all of the STD program that we currently have, is that correct?
Right. Any
And
harm reduction grants, we contract with Heartland Services, and it's their
Okay.
staff that is doing, they run our harm reduction programs.
Okay. I'm just
Any
trying
Any further questions before I call for a motion for the board to approve applying for this grant?
So moved, is Peter.
Okay, for a second?
Second.
Eagleman.
Eagleman seconded. Okay, let's do a roll call vote. And Peter, do you want to do the roll call
Sure
vote?
can. John Eagleman,
Aye.
Sabrina Pennington,
Aye.
Bob Coddington,
Aye.
John Lebo,
Aye.
Jeff Butler,
Yes, take it. Unmute yourself, Jeff.
you got it. All right, Pete Zaleski, yes. Paul Ryder.
Yes.
All right. The next thing on the agenda, much to my chagrin, I totally left off nursing fees when we did our last fee increase and look at those fees. I didn't even think about that we were gonna have to have nursing fees in there since we split from the clinic. So I believe I've emailed everyone a copy of what I have down. I tried to make it broad enough that we cover everything and clear when we need it, like the vaccine administration fee. Instead of putting the Medicaid reimbursement rate, right now it's $15, but that just increased in the last couple of months. So instead of putting a dollar fee in there, I just put that would be whatever the Medicaid reimbursement fee is. I think it's legal to do that, but Ron, I guess I should ask you, can I make it that vague? or I guess it's not vague, I mean, it's whatever the Medicaid reimburses at is what we would charge.
I think that's a presumptively reasonable rate. I think the statute is, as it relates to fees, just says that you can't establish fees that are in excess of your actual cost.
Okay.
Medicaid is, Medicare, Medicaid reimbursable rates, I would be very comfortable with.
Okay. And then the STD administration fee, that's a nominal fee. Lead testing, the health screening at $10, I think is very reasonable, because with that, it would be glucose, cholesterol, and blood pressure. And then some of the other things we don't necessarily do, like the blood collection fee, but I wanted to have that in there that gave us the ability, as we open programs and stuff up, I don't want our fee schedule to limit us to be able to add programming to the nursing schedule. TB testing, that is basically $5 over what the cost of the test is of our cost. The shot record being $5, I put it at $5 because that's what we set the fee for paternity affidavit. There is time in ours, but my goal is to get everybody the ability to have the Indiana MyVax, and it'll cost them nothing. So maybe having a $5 shot fee will promote people to go and create their own MyVax Indiana log on, and they'll always be able to monitor the child's vaccination standards or vaccination schedule and where they're at. And then the self-pay vaccine, that's 10% over the cost of the vaccine, and self-pay for testing, cost of test plus 10%. The private clinic setup fee, that would be as if a business wanted us to come out to their business and do a flu clinic. I would like to have the ability to do that, but there is a cost to our department to do that, and I think that we should put that cost on that company. For schools, we wouldn't charge a setup fee for schools or any kind of community one that we were wanting to do. So like for example, if we want to do a immunization clinic in Cambridge City, we're not going to charge Cambridge City for that setup fee. But if X company wants us to come there, we would be able to charge them $100 for us, the gas and the time for us to come out there and set up a clinic.
Any questions?
My only concern is having a separate schedule for the vaccinations for self-pay and Medicaid. Because my understanding is we cannot charge less on a self-pay than what we would charge the Medicaid program. Or Medicare program for that matter. So we probably need a single fee, and then Medicaid and Medicare are gonna pay up to what their maximum is.
Well, so the way that our clinic is gonna work is anyone that's on Medicaid or Medicare can go through the VFC program. So the only thing that we will ever charge for those are the administrative fee. The administrative
okay.
fee. So this is for someone, and it's very, very rare that there's a person that doesn't qualify for either VFC or self-pay. But there are odd times where it's usually a 40 or 50-year-old that their insurance doesn't cover Tdap, and they want the Tdap. Their insurance won't cover it, so they're gonna pay for it out of their own pocket. So I just wanted the ability to be able to charge that, and I'm just trying to cover all of the bases.
Okay.
Any other questions? Okay, I call for a motion to approve.
So moved.
That's Jeff Butler. Is there a second?
John?
Who seconded? Please announce the name.
Eagleman.
John Eagleman seconded. Roll call vote, please.
John Eagleman,
Aye.
Sabrina Pennington,
Aye, yes.
Bob Coddington,
Aye.
John Lebo,
Aye.
Jeff Butler,
Aye.
Pete Zaleski, aye, and Paul Ryder.
Aye.
Okay,
Passes.
thank you. We have the base budget for the emergency preparedness grant. This is a grant that Wayne County has gotten several years. This program and grant's been around for probably 20 years. Not exactly sure how many years Wayne County has got it, but it looks like it's pretty routine grant that you've gotten. If you look at the grant, I have put in here for some storage equipment, and that's for when the clinic is all done, we'll be able to buy some storage shelves and stuff like that and be able to organize our PPE and stuff better than we have now, which is everywhere. You know, anywhere there's an open space, we have some kind of PPE there. So there's for that. And then.
What's the name of that grant, Christine?
I'm sorry?
What was the name of that grant? I didn't catch it.
That's the emergency preparedness grant.
Okay.
I can send this to you. It's a routine grant the health department has had. Maybe
Right.
Kim can tell you what it's been called in Wayne County. Kim, do you know what you guys call this? Because you guys have called your grants some different, maybe the bioterrorism grant is what it's been called here. Okay. Kim wrote on there, it's the bioterrorism grant. So on this, I've got the storage equipment, and then I would like to buy another trailer for storage. And then we have one right now, 800 megahertz radio. I would like to buy 3 more, and that would allow Dr. Jetmore and myself to have the radios in the event of a pod and the pod manager, which would usually be the RN. Right now we just have one, and that's Dan that has that. And then I'd like to have the trailers placard, so they say Wayne County Health Department on those, so they're more visible. The one that's probably the most is, there's a company called Vantage Point Consulting, that for $1,500, they will come in and update all of our plans. I would like to have, the support of the board to go ahead and have this company do those. They've done them for several other counties in our area. They have the expertise to do this. We just kind of fill in the blanks for them, but they get all of our plans up to date. Our plans are out of date here in Wayne County. And in the middle of the pandemic, I don't have time to update them. Dan doesn't have time to update them, but I think that it's important that we get all the plans up to date. So that's the thing. That's $1,500. The contract would not exceed $1,500 to do all of those. Then I would like to also do cell phone reimbursement for 3 employees. That would be Dan, the nurse, and myself. Since we don't have separate cell phones, we're using our own cell phones for after-hours calls. And this grant does allow for reimbursement of cell phone cost at $35 a month. And then have a mobile hotspot, so we'll have internet connectivity when we're at a pod.
Okay, this, Dr. Ryder, just for clarification, everything you mentioned is under this one grant?
Yes.
So it's all, the Vantage is part of that grant?
Yes.
The cell phone is part of that grant, and the other things you mentioned?
Yeah. The grant itself is $31,895. All of the stuff are, this is a reimbursable grant, and they're all allowable under this grant.
Christine, I want to thank you for telling us what the grant is, how much it is, and what you're going to spend it on specifically. That's the kind of information the board needs to move forward. Thank you for doing that.
Yep.
Any further questions before I move on to request a motion?
So moved.
Second, so that was John Lebo motion, and then Peter second.
Let's do a roll call vote.
John Engelman,
Aye.
Sabrina Pennington,
Aye.
Bob Coddington,
Aye.
John Lebo,
Aye.
Jeff Butler,
Aye.
Pete Zaleski, aye, Paul Ryder.
Aye.
7-0.
Right. The only other thing that I have under old business is, we talked about, maybe having this company help us do the credentialing, and, they're working on getting everything, done and us credentialed, with Medicaid and Medicare and taking care of that. It became too hard for me to untie, with the clinic and the move and stuff, so I've gotten everything for Dr. Jetmore to this company, and we're well on our way to get this all done. The goal is to be all ready for July 6th opening, and we'll be square with Medicaid and Medicare to be able to bill and all of that, so.
Okay, this, Dr. Ryder, is that for informational purposes, or did you need a motion?
That's just informational.
Okay, and then you also had purchase, VaxCare's purchase of private vaccine.
I talked about that under the clinic build out. They came in, we had our onboarding, they purchased all of the vaccine, other than the 300 out of date flu. They didn't purchase that, but the grand total was like $14,000 to be paid in installments over the next 3 months.
Any further questions or comments? I think the next meeting, if we meet on the third Thursday, will be July 16th. Any problems with that date? Okay. Last chance for further comments or questions?
Yeah, I've got one.
Okay.
Oh boy.
That article you sent from Dr. Osterholm
Yes.
was very sobering. I mean, we hear Dr. Jetmore saying random in Indiana was 1.5%. We're doing this, and Dr. Osterholm, who appears to be very learned, I don't know if this is his opinion. I've never seen anything as sobering that says that 60 to 70% of every American is going to get COVID in the next 18 months, and 800,000 to 1.6 million people are going to die. Gee whiz, I'm ready to get, crawl in a fetal position, get under the bed right now. Can somebody give me some perspective on this?
Well, that's Dr. Ryder, and I think that's somewhat worst case scenario in meaning that there's no mitigation or ineffective mitigation. He also is ignoring advances in treatment, which appear to be happening, which would reduce that rate. The other thing that's coming out in the basic science, which is sort of confusing, but it appears that some part of our population, in fact, does have some antibody protection against COVID-19. That's very preliminary evidence. How much of the population has that and how effective that is, does that explain why we have asymptomatic people or why a lot of people are mild? There's just a lot we don't know. I think he's assuming a worst case scenario. But there's other information out there that as it comes in, I think will have an impact on those kind of numbers.
Well, and thank you for sharing this information as it comes forward to you, Dr. Ryder. I appreciate getting the updates and reading what's going on. And I certainly like to hear good news as opposed to just bad.
Dr. Jetmore, did you want to make a comment?
Yeah, I read that same report, Bob, by Dr. Osterholm. He cites that 60 or 70% as kind of an endpoint of getting to herd immunity. I don't know if that will ever happen, or even if that exists for this particular disease. I don't think anyone knows. There's so many things that, first of all, we don't know, the people who have antibodies, how much protection they're having from their antibodies. If they do have protection, we don't know how long the protection will last. I think you were wanting some good news. I think well, first, let me give you the bad news first. I don't think we're going to have a vaccine for at least a year, in spite of the wishful thinking of our political leaders. But however, I think we'll develop within the next possibly 3 to 4 months more effective treatments for the disease. That's much easier to accomplish than making a vaccine that's readily available to the American public. Already we're seeing positive trials coming out with use of dexamethasone in people who are really, really sick from COVID-19. So that's a bright spot. But I think antiviral drugs are probably on the horizon. But I think a vaccine is at least a year off, and I don't think this is going to be over until we have a vaccine.
Yeah, this Dr. Ed, again, I begin to support you, Dave. I think HIV is an example. We have effective treatments. We don't have a vaccine.
Yeah.
That's a great point.
Thank you very much for the clarification, because obviously he didn't say worst case scenario. He wrote it as fact, is the way I read it. I go, gee whiz.
It's. I don't think we can consider it fact. It was, again, looking at the crystal ball.
Okay.
Any further questions or comments? And I entertain a motion for adjournment.
So moved.
Second?
Second.
Unless there's objection, I think we'll not have a roll call vote. We're adjourned.
All right, thank you very much.
Thank you.
Bye, everybody.
Thanks a lot.
Bye, guys.
Bye, everybody.
Thanks, everybody.